All right. Thank you for meeting your neighbor. We're going to go ahead and get started. So some of y'all probably saw me before. I was just on the plenary. Once again, my name is Charles Hawthorne. I am the Equity and Harm Reduction Project Manager at California Bridge. And the topic today we'll be talking about is anti-racism assisted treatment and thinking about how we're advancing equity in MAT. And so I'm super excited to kind of talk a little bit about this. Just real quick for folks who were not on the plenary conversation. I do at California Bridge. Essentially, what my role is helping lead our internal equity work and kind of think about what it looks like to do equity strategy as far as medication-assisted treatment in the emergency department across the state. I also am our harm reduction lead. So along with Josh Luftig, who I was on that plenary with, and helping support hospitals in getting naloxone for free distribution. We even have several hospitals, including Highland, which Josh did not mention, who are doing syringe access as well out of the ED. Really, really innovative stuff. And so it's my job to kind of support this little ecosystem that we have in doing that work. And so it's been really awesome. And yeah, once again, we have like this little disclosure thing. None of us have any like conflicts of interest or financial relationships or anything that would like behoove us to lie to you. And I might say a couple brand names at points, but those people do not pay me, so I try to avoid it. And so this is just general information that we just support you in really thinking about your programs and your processes. So let's go ahead and jump on in. So I guess I can give you a little bit more detail here. California Bridge is a program of the Public Health Institute. So we are a program within the big network that is Public Health Institute, which also does some work with National Overdose Prevention Leadership Summit, as well as California Overdose Prevention Network. They have a lot of other really awesome public health things that they work on as well. And then we are majority funded by the Department of Healthcare Services. And so a lot of our funding comes from them from right now through an SOR2 grant, as well as some other work other funding we get from the state, especially to do our grant making work for hospitals to hire navigators. So just a little agenda. We have about an hour-ish together today. And as much as I love to talk, I even love to listen more. So hopefully we'll have some opportunities to kind of share back and forth. Even with people on the chat, I can kind of see the chats as it's rolling through. So if you have any questions, feel free to drop them in here and I'll do my best to kind of keep up. I also have some support with that. So hopefully I won't miss anything. And so we're gonna start out by doing our little intro piece now. And then I'm going to give you a little bit of a rundown of California Bridge's equity journey. Where have we been? What is our process that Kara and I have kind of led California Bridge through, starting in the last year, but even prior to that? And then we're going to be talking a little bit about what it looks like to build capacity for advancing equity. What does it actually look like to do that within the medication-assisted treatment, the substance use treatment field? And then kind of wrapping up and doing some final thoughts as we get ready to head out right around 11:15. So a lot of y'all already saw this slide in the plenary. This is, I think, the only repeat. So I wanted to but I think it's a really important thing for us to kind of establish. I think so much when we're doing this work, we do really lean into a place of not being able to truly like jump into the really complex conversations that it takes to engage with this work. And so this is a model that Kara brought over, Dr. Tolles brought over when she started doing work with us, thinking about this like learning edge. And so thinking about that there is an unsafe zone. There is a place where you can kind of be so far that you're not able to actually show up in your role, that you get fired, that you don't do things and you're not able to sustain it. But there's also this space outside of your comfort zone where you can kind of try new things, where you can learn new things. And a lot of times when we start getting into equity and harm reduction work, that's what it's really all about. How are we stepping into that learning edge? How are we pushing ourselves a little bit further? How are we starting to break down the way that we look at the world? Something that one of my former colleagues, Eliza Wheeler, says a lot about harm reduction is people who find themselves in harm reduction are people who love to have their worldview blown up, who love to like look at these systems, look at these things, and you hear a story and you're like, wow, that is incredibly messed up. And that is not the way that I've been seeing the situation. Or like one of the things that was a conversation that came up when we had our youth MAT pilot conversation last week was doctors saying, one of these doctors are saying, I actually have not been able to get my patients into substance use treatment unless they go to juvie, unless they go to juvenile. When you go to juvenile or you get a probation officer, you get all these substance use treatment resources, but access to substance use treatment resources is really, really hard when you're just moving through the regular Medi-Cal medical system inside of that. And I knew that, like I thought about it, but I had never really thought about, wow, how many doctors literally push kids into the juvenile system because that is the only way they're able to get care. Wild. And it's something to think about. And so just really getting comfortable with like understanding that sometimes those concepts make us really uncomfortable. They're really scary, and sometimes they feel too big for us to really even handle and tackle. But moving into that learning edge and us creating space for us to just like really switch up the way we think, and not just take that risk, but like really handle that pain of giving up the way that we think about our work, the way we think about our world, and really trying to move into a new way of seeing things. Hi, dear. So yeah, so to start us out, I called this session Anti-Racism Assisted Treatment. And so there's over here, there's a book by Ibram X. Kendi called How to Be an Anti-Racist. I think it's a very good text. I think that there are pieces of it that are harder to apply within the medical context, but also ways that it maybe should be easier. So I think it's definitely a really helpful thing if you're really trying to dig into work of anti-racism. I think kind of anti-racism is like the verb of racial equity. It is what it looks like to actually practice it. And so up here we have a quote that is about anti-racism from the National League of Cities, talking about anti-racism is a system in which we create policies, practices, and procedures, I was talking about those earlier, to promote racial equity. It generates anti-racist ideas, which uplift the innate humanity and individuality of Black, Indigenous, and people of color. So BIPOC, you might have seen that term before. And it forces us to analyze the role of systems and institutions in the racial inequities we see, rather than blaming people. And so I really love the way that this quote is written, because what it really says for us is you're not allowed to play the blame game. You're not allowed to just point at people and say, you're bad, and if you get fired, we'll be all good, or if you do this, we'll be all good. Because what we know is all of these problems, all of these things we're seeing here, like baked into the core. Like they're not they're not the sprinkles on top of the cake. They are the flour. Like they are the thing that actually is holding together. And we really need to actually think about, how are we changing the core ingredients? How are we changing the ways that this functions? And it's a bit of a process. It's really hard. And it's something that a lot of programs have struggled to do. And it feels really interesting coming to California Bridge. And I give them this feedback a lot, where I'm like, this is actually the furthest that I've made it in an anti-racism, racial equity process with an organization, because a lot of organizations get stuck. They want to make these changes. They actually really do. And I think that's a lot of times where the heartbreak comes from, is they really want to make these changes. But at a certain point, it requires the changing of power. It requires the changing of policies and procedures. It requires us to actually analyze the role that these systems and institutions are playing in perpetuating this, instead of saying it's their fault or their fault or their fault, saying it's the governor's fault, saying it's this person's fault. It's like, no, it's the system, it's the whole thing. And we really have to engage with that. And even though that feels really nebulous and hard, it's the only way we actually move forward. Yeah, and like I said, if you have any questions or anything that's kind of piquing your interest, I love being interrupted. I am one of 4 siblings, and I come from a very talky household, so that's kind of just how we talk. So if you want to just raise your hand, or I'm looking at the chat too, so please throw them in as we're going through. I'm happy to kind of take a detour, because I want this to be useful for you. I want you all to walk out of this feeling like the challenges you're having or the things you're talking about are being answered. And near the end of this presentation, I'll actually have a lot of kind of pointer questions for us to kind of dig into the finer pieces. But if any of these definitions or context isn't coming through for you, please, please, please ask. So the next piece I kind of want to think about is, what has been our journey at California Bridge over the last few years? So I joined California Bridge in October of last year, and they kind of started their journey back in 2020, which is how so many people started it. So, California Bridge is a pretty relatively young organization. I think They first started in 2018. It was really interesting because my team at National Harm Reduction Coalition, where I was prior to this, we actually were brought on as consultants for California Bridge as we were starting to do all of this. The we's are getting kind of complicated there because, you know, I was we there and we're here. But when California Bridge was starting to build out their work, National Harm Reduction Coalition was supporting them and thinking about hiring people with lived experience, building harm reduction oriented policies and procedures. And when I moved into the role of holding that consulting piece for at National Harm Reduction Coalition for California Bridge, we actually started talking a lot about equity. And then they wrote a job description and I was like, wow, that looks super great. I think I'm gonna go ahead and jump over. My team in HRC was super supportive of it. And so it was really great to feel like I was kind of bringing together a big family of like substance use treatment and harm reduction and all these pieces that were feeling really good. And yeah. But how they essentially started out was how so many programs started out in 2020, which was with the murder of George Floyd and kind of the things that came from that. And you know, sometimes I even hesitate to say that because I think it kind of starts off on a bad foot because I think a lot of orgs like ran out the gate and tripped immediately right after that. Like they had all these ideas of what they wanted to do and there's all this pressure being put on every single org to really think about equity, to really be critiquing and to be critiqued of their systems. And so many people just were not set up to do it. And even in hearing about what was kind of happening at California Bridge prior to me coming on, they were having their own challenges. You know, it's a lot of different ways of thinking. You have people over here who really have a lot of trouble changing and they don't really see all the problem and we're all human. Why do we have to talk about race and all these things? And you have people of color and also often people who are more connected to communities of color on this side who have been yelling about it for years and now somebody gets murdered and now y'all want to be a racial equity organization. And oftentimes, even though both of those people do have like similar goals and are trying to do similar things, the way they're expressing it and the way those conversations happen are not always fruitful. And so what they kind of started with was doing an equity audit, which is something that a lot of different types of programs do. And because it is really helpful to kind of get like a 20,000 foot view of like, what does somebody who is doing this work looking at? And this equity audit basically came back and said, y'all are not doing a lot of things that are like messed up because you're also thinking about like California Bridge is a programmatic org. We don't do direct service. We're supporting other organizations, but we actually weren't doing anything that was promoting equity. We weren't thinking about this is what equity looks like. This is how we operationalize it in every bits of our work. And there was a question of like, if nobody here has the capacity to do it, then that's the first question. How are you actually building the capacity for it? And so the next step became creating capacity, having funding put on the line item to hire me and Kara. So they wrote a job description, they hired us on, they brought us on. And from there, we were able to start leading a process. And so for us, what that process looked like was we used a few different tools. So we had our equity staff that came on. So me and Kara, Kara is part-time. She also works in an emergency department, but she does a lot of organizational consulting work. She is the equity lead at UC Davis Emergency Department, and it does a lot of work in bringing them along in their equity work as well. Prior to me coming on, they'd also formed a racial equity committee. So they'd formed a committee of people who were talking about this, and they weren't necessarily really like guided, but they were there and they were passionate and they had built a really great dynamic within this group. So that was really powerful tool to come on. So thinking about bringing together like a powerful small group of people who were really interested in promoting equity and had kind of the space to talk about it. And then the project that Kara and I started was doing these things that we called racial equity pauses. And you know, first I kind of hated the name racial equity pause because I'm like, this is like a workshop. This is a conversation. We're not stopping. But you know, we work with emergency department doctors. And so asking them to pause is hard enough. I don't know if any of y'all have like talked to an emergency department doctor recently or nurse or anybody, but they move very, very quickly. They are like squirrels. And asking them sometimes to slow down and think about strategy can be really, really hard because they are constantly in a place of treating, of managing, of handling, of helping, of serving, but it's not always about thinking. And so we have these pauses, which are these things that we've implemented to kind of slow down and think about it. And these pauses kind of built on each other. We started out with like actually like that anti-racism slide that was from that presentation, thinking about what is racial equity? What is anti-racism? What does it look like? And then we moved into a conversation about, you might have seen a paper before talking about characteristics of white supremacy culture. thinking about what does it look like for racism and white supremacy to show up at your org, thinking about things like having a sense of urgency about everything, things like worship of the written word, things of people with power having a right to be comfortable and not be critiqued. All of these things that showed up in different ways at our organization. Some ways that were felt really hard to avoid, and some ways that were like, wow, this is like really fascinating to see show up and actually be able to push back on it. And so we started getting language to talk about that. And then we moved into this other piece. So one thing that I love about California Bridge is we have a lot of materials. We have a lot of resources. If you go to our website, californiabridge.org, you can click our tools and resources tab. And let me tell you, there are a lot there. And so the first thing that we really started thinking about is how is equity showing up in these materials? We have a material about racism and substance use treatment. We have a material about harm reduction, but how are we actually thinking about this in all this? What does it mean to talk about equity in a Butte Quick Start Guide? What does it mean to talk about equity in a nursing pamphlet? What does it mean to talk, and really think, so we started having a conversation about that. And then from there, what we did is we actually started creating a work plan. And like I said in the plenary as well, one of the main things that I say a lot during these pauses and during my role is, I am not about to be the only one doing equity work. I refuse. I really refuse. It's really interesting. So I mentioned this earlier as well. My mom actually is a career DEI worker. She has worked at a pharmaceutical company where she helped create their DEI program like 25 years ago, has been working in it for decades, recently moved into a different role, but is like still an equity consultant. And something that she said to me before is equity is not a passion, it is a skill set. It is a thing that you do, that you learn how to do, and then you enact it. And that means that you can attach things to it. We do all these other SMART goals and objectives, and we have all these patterns for how we do it. How do we put that into a work plan for equity? And so what I tasked people with was, I wanted every team, we have our communications team, our operations team, our navigator team, all these teams. And I was like, I want everybody to write 1 or 2 goals that we're gonna put into a work plan. And you might have heard of like SMART goals before. So goals being specific, measurable, or achieve like all these things. And then like being realistic, time-oriented, like all these pieces. We use this thing called SMARTY goals, which added an I and an E, which included inclusion and equity. How are you really centering inclusion and equity? And so that looked a few different ways. So my slides are kind of messed up, but it's fine. We had to change it. I think they ended up changing it to a more accessible font, which is very important, so as everybody can read, and it kind of got messed up in the process. Happens to the best of us. But what this says right here is we had a few questions that I offered people during this workshop, where I wanted them to do a bit of an exploratory process, because I'm very gentle. I'm like, let's walk through this, baby steps, before I just throw y'all in, because it's not effective. But some of the questions that I presented to people was, what was your equity update this year? We did a workshop together where we talked about all of our equity wins. And so we were in a big group, and it was like 30 of us. I'm like a big like note card, sticky note kind of facilitator usually. And I was like, I want everybody to write, what was something that you did in your role that promoted equity? And people said things like, we reviewed our hiring process and we removed education requirements. We reviewed all of our materials that mentioned race and really talked about how we were showing up in those materials. We prioritized hospitals that primarily serve patients of color. We went after funding that was specifically to serve tribal MAT programs. All of these things that when you do it, they're kind of disjointed and they feel right and they feel good, but you don't necessarily bring it all together. And by the time we got to the end of that conversation, we had a list of like 50 things that we had done in the past 2 years that had promoted equity. And so when people looked at the list and they saw the roles that their teams played, they were like, okay, there's these things that we're already doing, and there's like these little holes that I think can kind of be goals for the future. Also questions like, what are your opportunities to incorporate equity into your work, into tasks that are already on your work plan? So I love our executive director, Serena Clayton. She is a very serious woman, and she is very real about everybody needs a work plan. Everybody needs objectives. We need to talk about what you're doing, and we have team objectives. We have individual objectives, all these things. And so an important thing for me was thinking about, this isn't about adding more work to your plate. It's about changing the way you do your work to be more equitably aligned. So if we're already doing things, we're like reviewing our materials, how are you doing that in a more equitable way? Maybe even thinking about what are some areas you're already working on equity that you could kind of explicitly highlight and lift up. So some things that you're doing that are kind of like low level that you can say, like, you can beef it up, you can really present it as something really good, and we can highlight that as work we're doing. And also even coming back to how does equity work look within your role? So I think a lot of the times, as a program person, it feels really easy in a lot of ways for me. Like, equity looks like talking to people of color. It looks like incorporating their opinions. I did my master's program. A lot of what I focused on was community-based participatory research. How are we bringing community into the way that we're doing research, the way that we're building programming? And so, it's very natural for me. Like, that's just kind of the way I've always done my work. Our operations team, it's new for them. You're used to handling billing, getting people paid, checks, very cut and dry. And there are opportunities for you to do it. And so really starting to think about what that looks like in your role. So one example, so we have actually created a racial equity work plan. And it's still getting finalized for now. But like one example of this is, so I gave people a few categories, which were approve and initiate new things, sustain things we're already doing, or an advanced practice that is going to take us to the next level. So for example, one example we had was from our communications team, which was improve and initiate. And so the goal they came up with was integrate DEI priorities into new resources during the planning process for new clinical resource development, starting in fall 2022, considered for each item. So for every single resource that we're creating in fall 2020, starting in fall 2022, we are going to talk about these DEI priorities that we've created, and we are going to be considerate for each item. What that has kind of started to look like in operationalizing that is it was kind of the thing that I kind of started talking about. We're like big Google Docs people, so everybody's like commenting and editing and all that at the same time. And there was this phenomena that we talked about in our racial equity committee where people were like, sometimes I like read something and it just like hits me wrong, but I don't really know how it's wrong and I don't really have a language to fix it. And so if I say something, I feel like I'm going to get tasked with fixing it and I don't actually know what to do. So sometimes I just rather not flag it at all and not deal with that, which is very real. And I was like, okay, so how we're going to operationalize this is when you're reviewing or building material, just flag it. Like literally highlight your section in the comments, say equity, ? And that gives us as a team and gives us as a unit an opportunity to come through and read that and maybe say, that's really interesting. Maybe we actually don't really need to switch this up right now or add something somewhere else. And maybe sometimes it is really important. It's like, oh yeah, this is a really important part for us to maybe talk about equity here. So one thing that we do a lot is like giving like patient vignettes. So like, this patient is a 24-year-old Black woman, homeless, has cardiac issues, does these things. And kind of thinking about, all right, if this is a Black woman, like how is that actually impacting how she shows up in care? What are the priorities for this? What are the things that you want a clinician reading this document to know and recognize about this patient, and how you're supposed to be supporting her when she's coming in for care? And so really pushing all of our people to really engage in this and really start thinking about it. And then along that, we have these SMART goals. So actually what we did on one of our racial equity pauses as well is we critiqued each other. We said, here's your goal. Is it strategic? Is it measurable? Is it ambitious enough for us, but realistic? Is it time bound? And also, how are we including people and how is it equitable? And I will say one piece of feedback that came back on this was us thinking about how we are including people of color and people who use drugs in our material review. And it was a question that came up as part of that, which was like, we're still working on answering. We're a small org. We write really clinical papers. What does it mean to bring people in and have them be meaningfully involved in our creation process, while also moving with like the speed that we want sometimes? And that's something we're figuring out. And it was a question that came up because we started reviewing these goals through this kind of SMARTY lens, and we're able to start kind of evaluating it. So yeah, that's like there's been a really huge thing that's been really supportive of us starting to move forward. Okay, wow, that is about all I have for slides. So now what I want to do is kind of move into a bit of a conversation piece to kind of start talking about how this has been showing up at your org. And so once again, I have like the chat in front of me. So if anybody is on Zoom, you're so welcome to share your thoughts as well. And I'll kind of read them out to the room and we can kind of have like a big hybrid conversation. And so the first thing that I kind of wanted to put up to have us start thinking about is, how do you see anti-racism fitting into your role at your organization? So we can think about how it's important in all of it, but I'd love to hear from people. It's like, what is your role at your organization? And what do you see, based on like what we've kind of talked about so far, how do you see anti-racism fitting into it? Yeah, go for it.
My name is Rachel. I do addiction medicine here in Sacramento at a federally qualified health center. And so I think, and I am the lead for our program there, and see both patients, but also have this admin kind of role. So it's a small program, small staff, but we have clinic size of like 30,000 patients. We're here.
What you doing?
So on like a really basic level, in terms of health equity, I think our primary mission right now is in access to buprenorphine. So we could just kind of take that as an example. So I would say in a big part of my job is I feel thinking about long-term sustainability of our current state being, we actually, like the people who are getting access to buprenorphine do actually match like our demographic area right now as like a newer program. But I see long-term, if you maintain like equal access for everyone in the current system, it really does, kind of, we're going to see the similar things we're seeing in the larger state where it's like, more like half of what you would expect, I think long-term. And so I think my role is kind of looking at, how as an organization, I help support them in like looking at how we actually do treat people of color, Indigenous folks, all other, and in my clinic, especially, like we have a gender affirming care clinic, but the front desk doesn't always use pronouns, for example, it's a very complicated situation. So I see my role is in, really thinking about how do I convince or like get that buy-in for, we actually do have to treat folks differently. We can't treat everybody the same or we're going to get the same results. We can't keep doing the schedule in this Q 20-minute, way and like not having any kind of flexibility to maintain like this. I think it's an amazing thing we were able to do in the beginning, but I think my role is in kind of looking at how strategically we can sustain that. And quite frankly, it probably isn't good enough. Like with the data, you would I think probably if the overdose deaths, if that data is true, you really should have a higher demographic proportion of BIPOC in your program than folks who are white demographically speaking. Anyway, that's my.
That's super helpful.
Thank you.
Of course. So you have kind of that strategy piece. What does it look like to build a forward system? And I think it's really beautiful that you're like thinking about that now. I hate doing this type of work when we are already like stuck, like when you're already in the hole and you're like, you've already severed a lot of relationships. You've already done all this work and like in the wrong direction. And so it's awesome to hear that you're thinking about what are we doing moving forward? What is the strategy? What is the sustainability? How are we making sure that people of all different types feel welcome ongoing? And I love kind of thinking about that like gender affirming care space and like, okay, there's this dissonance of like, we have this space that is a huge resource maybe for trans, non-binary, queer folks. And how is our front desk being properly trained up? And that they're able to make sure that these people have a really seamless, welcoming experience from the time they walk in the door to the time that they leave. And those are the huge questions to kind of start putting forward. So thank you for that. Any other thoughts? Oh, cool. Let me go ahead and read some of these. Yeah. So we have like thinking about, so having providers who are able to communicate in a person's native language, as well as program materials and program supports. So thank you for that, Catherine. April added peer specialists from the community, which is Native American. So in a similar way of thinking about how are we bringing in people who can directly communicate with the people we serve. And, this was such a fascinating thing that came up. We have a group, you might have heard of the YOR grant, Youth Opioid Response, which is under MAD Expansion Project. We have funding through that where we've been supporting hospitals and doing some youth opioid response work. And something that came up in a workshop that we had with this team last week or the other week was people talking about kind of these racial differences in how people show up. And one of the big things was around Latinx patients and Spanish-speaking patients specifically, and thinking about the value that people have felt and not having to use a translator and like having a provider and a provider team on site who can just talk in Spanish, who can just communicate with people in their native language, because that's what actually helps people feel more comfortable and feel more welcome. And you have like, when you're in a situation where you have an 8-year-old doing medical translation for their parent, like that's not equitable. That's not helping people get the high quality care that they need. And so really starting to like build that is huge. So yeah, thanks for both of those comments. And then we have like, let's see. So I believe Andreas added, I believe we are doing well in treating everyone as humans without any labels. Main goal is treating the individual and meeting them where they're at that time, making sure we're able to get the message across at any needs. So yeah, and I think this is such an interesting thing because it comes up a lot when we do equity work, this concept of like humans. And it's like, yes, absolutely, we are all humans. And I think that sometimes I think that labels are such a fascinating thing. I think there's lots of labels when we start talking about the medical system. We can talk about those identifying demographic labels, race, gender, background, all those things. Labels like diagnoses, labels like stigma, stigmatizing slurs, all different types of labels that serve different purposes within our society. And I think that labels sometimes can be really unhelpful. I have a colleague named Maurice, who is a therapist in a harm reduction therapy center in San Francisco. And one thing that he's kind of talked to me about is when he would bring in new youth. So he did a lot of youth counseling for a long time with Homeless Youth Alliance in the city, great program. These youth, usually 16, 17-year-olds at this point, had been diagnosed with like 3 different mental health disorders. They were bipolar, they had borderline personality disorder, they were schizophrenic, they were all these things. And the first thing that he would ask them was like, well, what are all your diagnoses? And which one of these feel helpful or real to you? And so much of that was really about helping people both like understand that these labels are something that might provide framework and benefit. It helps you describe your experience. It helps you find community. It helps you add perspective to your environment. Much like, as a queer person, what it felt like to be able to have a label and have an identity of being queer or being non-binary. It's helpful. It gives a structure to your experience. And if that label is unhelpful, we don't want to use it. We want to figure out how are we holding people. And so, usually when I actually talk about this work, I don't actually usually ever describe people as having addiction or substance use disorder. Usually I just say they use drugs. Because if people want to take on that label, if being an addict is a hopeful label for you, it is not my responsibility to take that away. It is my responsibility to tell providers to not put that on people if that's not their job. But to really let people determine that. And I think to connect it back to thinking about race, I think that sometimes people don't feel like talking about their race or having a racial identity is necessary for being able to frame their care. I think it is for me. I think if my provider is not able to recognize me as a Black person who has a Black experience when I come into this emergency department, I don't actually think that they know who I am. I don't think that they're actually interested in providing me high quality care. I just don't. And so sometimes our discomfort with labels can come from that desire to just kind of avoid all of those feelings that come up when we start getting into it. And it can be real easy in some situations to label, in other situations to say, I don't want to do labels because of our own discomfort. And so really also thinking about when we're doing patient-centered care, how are we putting the power of the labels people have into their hands? You get to choose which of these are helpful and which of these are not helpful as you're kind of doing this work. And then kind of thinking about, we have a couple more in here. So Deanne had added, I agree, our patients that we are treating match the patient population we are in, which is primarily Hispanic. However, we definitely have room to grow for equity education in the community, outreach and marketing for MAD at our clinics. I love that. So thinking about building this space but outreach, that piece of bringing people in and making sure that you are reaching out to the right people in the right community. And that's something that has been so beautiful with our ED work. So I, like I said, I came more from like syringe service world. And so I have a lot of really awesome connections with harm reduction and syringe service programs around the state. And so being able to start to build these connections between EDs that do bridge work, syringe access programs that are already connecting to people who want this care, who the ED is really like the place where they're getting medical care anyway. How are we building those connections and really starting to do that outreach and then connecting with people who are already doing that community work? And we've been talking about like connecting with churches, connecting with schools, connecting with community programs that are already doing different types of clinical health support work, people who do documentation and name changes, people who do for trans people who are doing immigration and paperwork and consulate work for people who are immigrants. Like all these different things are really, really helpful. And April added this piece. It's important not to take people out of their culture. Many of the people I work with are very much affected by intergenerational trauma and ongoing racism. So yeah, thinking about how we let people stay themselves. How do you get to show up fully as who you are and be treated with care? And I love that piece around like flexibility and thinking about how do we show up and really allow our services to bend and flex and not be so rigid that people have to be in or out. And you know, all of us kind of work in different spaces. I know at the ED specifically in the emergency department, that's something that's like huge. And that's something that I have found the most connection with people we're starting to do this work with who are very new, who are uncomfortable, but understanding that the ED is a place like, what is that Tim Gunn says on Project Runway? It's a make it work moment. All of the emergency department is a make it work moment. People figuring it out, people like getting it stuff from here, going there, doing it, running, doing this and giving this person CPR cone over here and like putting a line in, like all these things all day. And I think the more tools and resources that these teams have to do this work, the better they're able to do it. And when you're able to do that for patients within the context that's helpful for them, you get even further. Awesome, right here and then back here. Oh, cool, we got a few. Let me give you the mic so everybody online can hear you too.
I was just going to also add, because my role is a little bit different. I'm kind of have an administrator role. And I think for me, there's a couple of things. One is decoupling whiteness within our organization. Like so I think there's two things. There's equity and then anti-racist practices. So what does anti-racist treatment actually look like? Which I think is something we have not investigated and need to. Like what is it? Because it feels like it's a white-centered or white-led treatment modalities. It's like, I feel like we understand the equity piece, but then we don't know how to move that along. Like we're like, okay, well, how do we move that? But then for the biggest hurdle for me has actually been within anti-racism is getting people to connect how drug policy is actually should be part of our everyday work, that drug policy is directly related. And so we have to actually understand this. We're part of it. I don't think we can actually be removed from it. I don't think you can say, oh, I'm a clinician and I have nothing to do with policy. Clinicians have the most power usually. So I just think those are types of things too, that even like from maybe a different perspective that's been something that I've been hopefully trying to work on, is like, how does policy actually intersect with.
What was your name?
Amanda, sorry. Claire Matrix. Yeah, thank you.
We had a couple more. I know we had back here and then we have maybe like two more and then we're gonna go to the next question.
Hi, my name is hello. I'm a substance use disorder pharmacist and that works in a clinic actually at UC Davis. And so I work with a lot of your bridge people. I know, a lot of your folks. And so I'm on the suit team, part of the suit team, part of the subcommittee, all of that. One of the ways that a pharmacist, we have Holly here, works on the inpatient side. I work on the outpatient side. And my clinic is very small. I have 2 addiction psychiatrists. I have 1 CSW, and then there's me. And of course, we can't reach everyone, right? And so we're limited, and we have outside resources. But so part of what we do at UC Davis, we do a lot of research. So I'm involved in a lot of that research with pharmacy residents. We do a project every year. So my project this year is on alcohol use disorder and getting better access to Vivitrol or naltrexone for my patients, because it's very complicated to order Vivitrol. a lot of primary care providers are like, well, what's Vivitrol? I don't know how to do it. I'm scared of it. Like, don't know how to treat alcohol use disorder, or even talk about alcohol use disorder with their patients. So, and also it's a very complicated process along with like actually getting to figure out, is it a pharmacy benefit? Is it a medical benefit? Where does it come from? Who do I talk to? And so one of the things that I know is that there are a lot of patients that don't, backing up a little bit, there are a lot of patients who are like, they go to their primary care provider and they're like, I don't want to go to a SUD program, right? Like, maybe I just need some help with, can you just give me a med to help me reduce my drinking? But I'm not ready to go to a SUD program and meet the LCSW and talk about my feelings yet. Maybe I just need a little help to like get me started. And so those are the people that we're not accessing. And it's at the point of care, like in the ER, you were saying, it's at the point of care at the primary care doctor's office. So what we're actually doing is we're working on a smart set order set for Vivitrol to make it a click situation. Number one, we're also doing pharmacist-led education. So we have a pharmacist at every site in the clinic. And so all the pharmacists are actually doing like education for their providers. We're doing a pre and post survey to find out like, is our education actually useful? And are we reaching more patients? And of course, like we'll be able to validate that with Vivitrol orders and to see if like our smart set and our education are actually useful. So that's one of the ways that we're reaching out and doing more things.
So you have these. Sorry for people on Zoom. You have all these little pieces. You have this thing around the procedures that you're creating. You have these things around like your research and how are you evaluating the work that you're doing. All those are so huge, and so it's really nice to hear that. I actually didn't know about all that happening at Davis, so good to know. Thank you. And then we had one over here and then one over here. Perfect.
Good morning. My name is Teresa Whitney, and I'm the manager at the addiction program at Father Joe's Villages in San Diego. And we're a federally qualified health center. One of the things that is really difficult is seeing the disparity between what we know is equitable and fair, treatment and what is actually being delivered. We're surrounded by tents, and a large portion of the population out there on the street are Black, Indigenous, people of color, and yet we're the number of folks that are actually in our clinic is maybe 16%. So one of our goals is to increase the offering to Black and Indigenous people. How do we do that? It feels like this huge undertaking. Is it around marketing? Is it around education? It's all of that. But it's also about our own internalized becoming an ally. And what does that really mean to become an ally? And looking at our own biases, our own internalized, racism and homophobia and all of it. And that's tough work, right? And so I think that, as I look at trauma, we have to come from, looking at, what people have been through, not just personally, but ancestral, we carry all that with us. And so I can say, yes, I want more Black people to come to our program, but do they feel safe? Do they feel welcome? And not even they, I don't even like to use they, because it's that's that separation piece right there. But looking at, Black body trauma, white body trauma, blue body trauma, you talked about the police in the last one. And it's true. It's like, that's scary. We have an officer at our front doors. Well, that's scary to somebody who's using drugs, isn't it? Right? It's complicated. Exactly. That makes them feel safe, right? So, looking at, you talked about that brick wall. Well, as a manager, I feel like I should have some power. I have no power, zip, zero, nada. Really. But the best I can do is, at times is, when there's opportunities, be an advocate. And what does that really mean to be an advocate? Sometimes we have to, because I look at the upper hierarchy and it's all white, you know, a little spattering of, Spanish in there, but we don't reflect the demographics of the people that we serve in a way that would be really beneficial.
My name is Jenny Wilkins, and I work under Teresa. I am a substance use disorder counselor and an outreach worker. And we have a street health team that goes out into the community, into these tented areas. And what I have noticed is my team, when we come upon an encampment where there's people moving too fast or there's people hunkered in the corner and they're using, my team goes, I don't feel safe going over there. And so what's important for me to do at my organization is have these conversations with the rest of my team and be like, why do you not feel comfortable going over there? And help them identify their own biases, their own stereotypes, and, be an advocate for those clients, because that's the demographic we need to reach. That's the demographic that surrounds us. And those are not the ones who are coming into our clinic to seek care. So I need to be an advocate for those people and continue to have those conversations with my team.
Right. All right, last one.
All right, no pressure, I guess. So my name is Erica Chavez. I work for Granite Wellness Centers up in Placer County and Nevada counties. And I am the grant manager and adolescent program manager. So I kind of want to touch on the fact of like incorporating all of these ideas kind of into the actual operations and functionality of your organization as a whole. So we're pretty much all here because we got some grant funding and a lot of us chased down a lot of grant funding, right? I am like a huge advocate of telling everybody that all money ain't good money. So you can apply. There are certain things that like maybe it's not in your best interest to apply to, which I know a lot of CFOs and financial people will probably be like, oh, I can't believe she just said that. We need money. We need to operate. And while that's true, if if we're aligning ourselves with certain people that, don't necessarily align with advancing, our mission and everything like that, then that's going to be a really huge conflict of interest in the future. But on the flip side of that, there's also people that sometimes we ask for money because we know that they have foundations, we know that they have money, but yet we're not actively working to mend those relationships and keep them alive. So for example, we've got a really large Native American community and they give out money. I will not be asking them for money this year. I checked to make sure my CFO wasn't in here. Because we have not done the work for me to feel comfortable asking them to support us when we haven't, in my opinion, done anything to support them back. Yeah. So again, like we can't be asking people for things, we can't take everything. And even in, let's say we've got events and donations, if we're taking participant pictures and it's nothing but these like blue ribbon board member folks, and we're sharing that to social media, that doesn't seem like a very like comfortable place for a lot of people to go. Like, oh, okay, so we understand like what these pictures are looking like, and just kind of thinking of it through that lens, a behind the desk keyboard sort of situation.
I love that. Thank you. This is all so wonderful. And I could not have planted y'all better. It was so perfect to see all these like different perspectives of coming through from this place of like program management, pharmacy, direct service, grant making, background work, like all of these things. Equity and grant making is like I could talk about it for a long time. I think that it's huge. And I really am impressed with like the perspective that you're taking on it, of this idea of like, it's about relationships. And I think that if you don't focus on the relationships, what you focus on is the dollar amount. And so when you're actually, I love that, of like, how are we leaning into our relationships, leaning into the things that are going to make sure that we are building these things for the long term, and we're supporting these communities in a very reciprocal way. It's like we do provide services. That's huge. And we're thinking about like, what are the things that people are offering for us for that? And how are we making sure that we are in relationship with them in a way that feels healthy and nice and good? Okay, so we have about 10 minutes left. So I have kind of one other question, which is, and I feel like we've already kind of started touching on this, but I'd love to hear from maybe a couple of people about these two questions, and I'll put them up together. Oh, this does not look good. This is not past the equity test, the accessibility test. So I'll read it out loud. Okay, cool. You know, we all learn about accessibility every day. Good to know pink on gray does not work. It does something all right. But the question we have up here is, what is challenging about incorporating anti-racism into your work? And the kind of couple with that of like, because I don't like to leave on a bad note of thinking about how can you center equity in your workflow? And so when I say workflow, what I mean by that is every day we we wake up, we sit down on our laptops and we start tapping on our laptops all day. Or we're going to see patients and we're doing that all day, or we're doing these things and you have an energy. You know, you think of your average week at this job of like all the steps you take, all the meetings you go to, all the conversations you have, all the decisions you make. And really starting to think about how do you censor equity in those? So we have probably about like 5-ish minutes or so with some change before I kind of have to transition into closing out. But how do you see yourself either what are some of maybe the challenges that have come up with you around centering equity in your workflow, and what are some opportunities you see for that? Okay, perfect. 1, 2, 3. And then there's somebody over here, I think, too, maybe. We'll see. All right.
So I'm a middle-aged white woman and I work with all demographics in my job, right? Like everybody. And so how does it not look like I'm overcorrecting or overcompensating in some areas? So sometimes I don't, use all the racial equity I can because I don't want them to think that I'm overcorrecting for some reason and give them a bias that I don't even, have. So where is the line as a white woman not overcorrecting in this type of situation? I would love suggestion type things on that.
Cool. I think I'm going to open that up to the group. So maybe we can have these next few people go and feel free to think about any advice or any thoughts that are coming up around that question.
So I work with Sandy. I'm Anne at an FQHC called La Clínica de la Raza, and we're in Vallejo. So I think one thing that I came into the organization with as a naive white woman coming out of med school was this idea that anti-racism was just going to permeate our system because we are an organization that was, started by and for Latinx folks in Fruitvale in Oakland, in this neighborhood as a storefront clinic initially. And what I've discovered is that over the years, our leadership has become much more white and much more distant from the people we're serving. I'm in a community that's very different from Oakland, where, as Sandy was saying, we have an incredible amount of diversity, and we don't have great representation in terms of our staff when we're serving that community. And one challenge I faced, I came into the organization to start a program for people with a recent history of incarceration and chronic medical conditions called a transitions clinic, and just getting my organization to prioritize that work and seeing it as part of their mission has been a real challenge. And also the substance use work. There's a lot, especially in this time of limited resources, where my organization is really concerned about its overall financial stability as the COVID dollars are running out for FQHCs. There's this sense of we have to focus on core services, and core services somehow doesn't mean my patients. So that's something I'm really working on is, no, these people, when we look at overdose rates, these people have the highest risk of dying. And we really need to prioritize this population. And they're just as core services as the people who La Clinica has more traditionally served in Oakland.
Yeah, I think what you're really touching on that is like, how are the roles of organizations changing? Like COVID was and has been nuts. And so just really thinking about like, what does core mean now? Core is something different than it was 2 years ago. And so I love that you're asking that question.
Felicia, case manager, and I wanted to address your question, and then I have a comment. So I think one of the first things that you are able to do is share with them that you don't know. Listen, I'm a middle-aged white woman, and I don't know how to make you feel comfortable. Help me. What language do I use? I think that is the start. So for me, incorporating equity into into my position is acknowledging that I have prejudices, that my coworkers have prejudices, and that they often are the guiding force in ways that we treat our clients. And in that being said, acknowledging the fear and also being open to being challenged and not feeling that everything is personal, because I get called out on my name regularly. And so I've learned to say, well, how can this bitch help you? Instead, you know what I mean? Not just be, but bald headed.
And you a real one for that. I honestly, I really get that. That is beautiful. And I love that piece of really just thinking about like how to show up in like humbleness and being able to hold that piece of just like, I like, we are all growing. Like, why should any of us know everything? Like, that is the reason that we work in teams. That is the reason we form organizations, so that we can harness each other. And so I think that a piece that I'd add on to that is how are you is maybe thinking about who are the people within the organization. And sometimes that means leadership, sometimes that means staff, and sometimes that means clients that I recommend you pay, who you can talk to and say, how do we shift this service in order to make sure that you feel welcome, and the people who you work with and the people who you know and love feel welcome coming in here and getting exactly what they need.
Hey, I'm Ashley. Some of you may know me because I used to work on Hub and Spoke and was a grantee liaison. Some of the name badges I recognize, so hello. But I'm sorry I didn't catch your name in the front. Sandy? Okay. And one of the things that I kind of wanted to ask, and this is probably my social worker lens, because I go into like additional questions and I'm like, okay, so like what is overcorrecting at that? Is that what you were saying? Yeah, like what is that? What does that mean for you? What does it look like?
So I do interact with our patients with competence. I can pretty much speak and connect with anybody because as an addict myself, we are a diverse population and we do know how to connect with each other, right? And I'm really good at it. But I know that I've seen some organizations and people go in and they get offended, but then they can talk to me like it's no problem. So I think that some people are using, by overcorrecting, I mean like being so sensitive on what they're saying to the person that they're not reaching who they are. You know what I'm saying? That's what I mean by overcorrecting. Being so nervous to overstep or to offend somebody on trying to be so, perfect that it doesn't reach our people and they feel uncomfortable and they're like, I don't even know what was going on, and then they don't feel connected to that person. When people come in for substance abuse service, they want to connect and they want a little piece of you so that they can have that hope within them from you. Because we give hope. That's what we do. We instill hope with people. It lights their fire and hopefully they can change some part of their life. That's what we try to do.
Yeah, I love that. And I thank you for that prompting question, Ashley. I think that is exactly what a question that came up for me as well. And I think that the other piece that I kind of think about with that, and I love that framing, because it's something that showed up for me in harm reduction a lot as well. I think this will be my last comment. So if we're running out of time. But like, I think that something that I see all the time in harm reduction is you have people who come into substance use treatment field. And, I think this might be something to maybe connect with you around, like your coworkers who come in who do not have a relationship to substance use disorder, who do not have a relationship to drug use and addiction, and the way that they show up in that space of the way that they overcompensate around drug use and overcompensate around addiction and overcompensate around language around that. It's the same thing. It's the same process. It's this, and it's like, there's all this history, and race is very complicated in the US and like has all these like really deep traumatic roots and all this stuff. But in a lot of ways, when people show up, we are the culmination of all these experiences and identities that we've held throughout our lives. And in some places, I think that people are able to show up really, really powerfully. Like I know a lot of Black substance use counselors who have a lot of trouble connecting with patients around their substance use disorder, even Black patients. And and I think what it really comes down to for me is like what you were talking about, that piece of hope, that piece of connection, and finding that humane thread that is, this is how we can connect. And this is what I feel really comfortable showing up in. And this is something that's really hard for me. So if I get it wrong, please let me know. And it's something that I feel like comes up a lot with like transness and pronouns. And it's like, okay, like I'm working on this. If I mess this up, please correct me. I want to hear you correct me, and I want to be better because I want you to be helpful. And I think the more that we give people that autonomy, the more we say, you're supposed to be here. I might not always be right. It is not my job to stop you from doing this. And something I would say in the syringe access program all the time is you can come in whatever state, you can be happy, sad, mad, glad, all those things. It is my job to help you because I get paid to be here. And therefore, if I do something wrong, if I do something that doesn't make you comfortable, I want you to tell me because I want you to feel safe. And if you're not doing that, I just don't know how to go from there. And so I'm going to try and be intuitive. I'm going to try and show up and you give me feedback. And that's all of our own internal work of like, when people correct you, like, how do you show up in that? When people are unhappy with their services and maybe call you out of their name, how do you show up in that? And that's a hard process. And that's like the thing that we learn. And it's like something that I talk to about parents with their kids. It's something that I talk to around people doing care in all different types of spaces. But ultimately, I think what it really connects back to and think about it is, how are we actually building these services and building out the way that, like it's like thinking about like that ant hill, like each ant has their own thing that they're doing. And we are just a really small piece in this large goal of moving this potato chip into the hill. But how are you showing up in that role in a different way? And how are you really just making sure that all of that power and humanity that you have that brought you to this place, you're connecting back to that? And it's not something new. It's not like a random new thing that you are like needing to figure out. It's actually like kind of something that is something you're practicing, that you might have this little bit of skill already. It's about reapplying it, thinking about it differently, and really just like wanting to step into it and doing that thing. Like when you start learning piano, you got to start at chopsticks. You got to start at Twinkle, Twinkle, Little Star. It's a process. All right, well, that's my time. Oh, perfect. Cool. All right, cool. So this is my name and email. If you want to reach out to me,